All right. Good afternoon, everyone. Thank you very much for joining us in person and on Zoom. I'm delighted to see not just general adult nephrologists, also some pediatric nephrologists and some rheumatologists. Thank you for joining us today. It's my distinct pleasure to introduce today's speaker, Dr. Michael Walsh. He's a globally recognized leader in nephrology and clinical research. He obtained his MD and a master's in epidemiology and trained in internal medicine and nephrology at the University of Calgary. He then trained in lupus and vasculitis in Cambridge, UK, followed by a PhD in health services research methods at McMaster University. Right now, Dr. Walsh wears many hats. Yesterday at dinner, we didn't know how he fits it all into a work week. Some of his responsibilities include Associate Professor of Medicine, Nephrology, Health Research Methods, Evidence and Impact at McMaster University, Medical Director of Glomerulonephritis Clinic, Director of Clinical Nephrology Research Group at St. Joseph's Healthcare, Scientific Director of Canadian Society of Nephrology, Chief Scientific Officer of GlomCon. Several of our fellows are familiar with GlomCon. The Provincial Medical Lead for Person-Centered Care at the Ontario Renal Network, and the Senior Scientist at the Population Health Research Institute. He investigates not just glomerular disease, as we'll hear, but also symptoms of kidney failure and cardiovascular complications in patients with kidney disease across the spectrum of kidney disease. Dr. Walsh's work has transformed our understanding of autoimmune kidney diseases and dialysis-related outcomes. He has led or co-led over 30 major clinical trials, including the landmark PEXIVAS trial, which I think he'll talk about today. And he has authored more than 180 peer-reviewed publications in top-tier journals, including New England Journal of Medicine, Lancet, JAMA, and BMJ. He leads multiple clinical trials, as I mentioned, but he also serves on many committees, such as adjudication committees and data safety monitoring committees for many clinical trials. Related to my area of research, he is one of the principal investigators of the phosphate clinical trial, which we're eagerly awaiting because this is a big global pragmatic clinical trial that will hopefully tell us more about where our serum phosphate levels should be in the dialysis population. Beyond his research, Dr. Walsh is a passionate educator and mentor. He has supervised dozens of graduate students and medical trainees. Many of his accomplishments have been recognized by numerous awards, including from the Canadian Institutes of Health Research, the Kidney Research Scientists Education National Training Program, McMaster University, Alberta Heritage Foundation for Medical Research, the Society of Clinical Trials, Dalhousie University, NEFJC, and the Canadian Society of Nephrology. Yesterday at dinner, we learned that he does not rest on his laurels. He's about to take sabbatical and advance additional lines of investigation. So watch out for his name. In addition to results from the phosphate trial, I think there'll be more important results coming out soon. Today, he'll be speaking to us on ANCA-Associated vasculitis from evidence to personalization. Please please help me welcome Dr. Walsh. Thanks very much.
Thank you, Tamara, for that very kind introduction. I usually go by, hi, I'm Mike from Canada. So I'm going to talk a little bit about ANCA-associated vasculitis and particularly about how we try and integrate some of the evidence that's now been generated into the decisions that we need to make at the bedside. Anyone know where McMaster is? Oh, fantastic. Yeah, woohoo! Go Jays. So we're not that far away. We're at the tip of Lake Ontario in the city of Hamilton, which is a steel city. I didn't show you the steel mills because they are uniquely unattractive as a part of our city. It's also called the City of 100 Waterfalls. There's one of them that happens to be close to where I live. And that's Mac at the bottom. You can see Lake Ontario stretching up from McMaster itself. So encourage you all to visit. It's beautiful. Maybe not this time of year, but later on. I'll try and show you a few other pictures of Canada as we go. These are my disclosures. None of them are particularly relevant to this talk. and I will mention off-label medications extensively. Ironically, it's cyclophosphamide and prednisone, which are off-label for almost everything other than cancer, as it turns out. So just bear that in mind. So I'm going to talk a little bit about what is ANCA-associated vasculitis. That will be extremely brief. We're going to talk a little bit about the natural history of ANCA-associated vasculitis to try and set the tone for how we think about our patients, and then about predicting outcomes and the treatment options, and we'll try and tie it all together as we go. So what is ANCA-associated vasculitis? Well, it's a group of small vessel vasculitides that have a common tie in terms of a positive anti-neutrophil cytoplasmic antibody. For this talk, what we'll do is we'll limit that, calling ANCA-associated vasculitis, to just microscopic polyangiitis and granulomatosis with polyangiitis. I exclude eosinophilic granulomatosis from this talk because it's really treated quite differently. I put this up as what is ANCA-associated vasculitis. I usually put it up to, first of all, show which parts of it were included when I started training. There was only 3 things on the slide at that time. There was an unprimed neutrophil, a primed neutrophil, and some ANCA floating around, and then some tissue injury, and that was it. Now we filled in a whole bunch of other gaps. When I say we, I mean not me, but a bunch of other very smart people who have been really able to figure out much of the pathogenesis of this disease, which, as it turns out, has been actually quite helpful in thinking about new therapies. Clinically, of course, this is probably what interested me the most in getting involved in ANCA-associated vasculitis, and that it can look like anything. We have pictures across each of the columns here for GPA, MPA, and eGPA, but of course there's so much crossover between them, and you can see the vasculitis activity score, the Birmingham Vasculitis Activity Score, in the left-hand side there that lists out many manifestations. And I think that's what ends up being so exciting, is that this is a disease with many faces. It can affect people in extremely different ways. But as a nephrologist, one of the most, I'm going to argue, important and interesting components is that about 3/4 of those patients with ANCA-associated vasculitis have at least some involvement of their kidneys. And that can stem all the way from just an abnormal urine sediment to requiring dialysis at the time of presentation. So, natural histories. We're going to walk through in kind of 20-year blocks in very broad strokes. 1930s, really starting to name it, be able to identify organ manifestations of this common pathology, but it was all on autopsies. And that's what the outcomes were then. It was a uniformly fatal disease, possibly because of its late diagnosis, but really there was no known treatments for it at that time. In the 1950s, things didn't change a whole lot. The diagnosis was slightly less late, and there were still no real treatments available at that time. But at least now that it had a name, people could recognize it slightly before people died. 90% 1-year mortality at that time. In the 1970s, glucocorticoids had been established. Diagnosis was becoming even earlier. Alkylating agents were then used to try and reduce the exposure to glucocorticoids and glucocorticoid-related side effects. So we traded them off for the side effects of alkylating agents at that time. Dialysis was now a more commonly available therapy, and life was extended. Now the 1-year mortality ranged anywhere from 5 to 50%, depending on the type of presentation that one had, and it was dropping throughout that era. In the 90s, ANCA testing starts to become available. We start to refine what the diagnosis is and what the natural history is. And combination therapies or sequential therapies start to become an actual thing, and reducing glucocorticoids and therapeutic intensity over time becomes a thing as well. And the 1-year mortality has now dropped down to a pretty consistent 10% across most of the diagnostic range for these patients. In the 2000s now, we start to work on reducing treatment-related complications. 1-year mortality has dropped to 5%, and overall we're feeling better. But we're not done yet. The story isn't over. So despite effective treatment, first-year mortality remains unacceptably high, particularly in those patients who have advanced organ dysfunction at the time of diagnosis. And of that, about half is now due to infection, and about a third is due to active ANCA. And I would argue that, in fact, the line between those two is quite blurry. People get their active ANCA disease early on again. We immunosuppress them even further. They get their infections, or We've already successfully induced them, but perhaps the immunosuppression is a little bit heavy. They get their infection, and that becomes the beginning of the end. And of course, for any of you who have seen these patients, it's often not just one or the other, it's both, or it's multiple things, including coronary disease, other acute events that occur during this time. Developing a causal chain for them can actually be quite a challenge. One thing is quite true, though, and I apologize to the rheumatologists, but the kidney dysfunction at the time of diagnosis can really help define who the at-risk population for a bad outcome is. And you'll see in this graph on the right, years and years ago now, it seems, we made this graph out of the first wave of long-term follow-up for the UVAS cohort, so a series of patients who were enrolled in trials, 535 patients, and we just divided them into those who had what we called significant kidney dysfunction and those who didn't, based on an eGFR at the time of diagnosis of less than 50 or greater than 50. And those who had less than 50, it was dominated by the outcome of end-stage kidney disease with a fair bit of mortality thrown in over that first 6 months to 1 year time. That was really why we started to target this as being the most important time to try and come up with changes in therapy. Although I still argue that from a clinical interest, it's really the long-term management that we often struggle with, think about, try and figure out what we're supposed to do. It is, in fact, a little less bang for your buck in terms of trying to get patients a good outcome. So we're going to try and root this discussion in two different patients. They have several similarities, most of which is in black. Then they have some differences, and if it's a bad difference, it's in red, and if it's a good prognostic difference, it's in green. So our patient, case 1, presents with some systemic signs and symptoms, weight loss, arthralgia. They're clearly inflamed. Their kidney function has gone off. 425 is about 5 mg per deciliter, as I recall. Hemoglobin of 88, which is low, but not profoundly low. And the rest of their blood work looks okay. They have a few infiltrates on their chest x-ray, but they're satting okay on room air. Patient number 2, same systemic symptoms, but coughing up a bit of blood. They're also inflamed. They have preserved kidney function. They have a much lower hemoglobin. And then they have infiltrates on their chest x-ray and require supplemental oxygen as well. We'll be coming back to these cases over and over again. First picture, this is close to where I grew up in Western Canada and the Rockies. It's beautiful. It is the stereotypical picture, and I will not break from stereotypes for this talk. I will only present Canada as being a land of natural beauty. We do have cities too, but few and far between, mostly punctuated by scenes like this. Okay, so treatment. Back when I started, this is what we had. There was 3 things. You give people oral cyclophosphamide, we could give them glucocorticoids, and then we would give them some azathioprine once we felt like they were in remission, somewhere between typically about 6 months, sometimes a little longer, sometimes a little bit shorter, depending on how we were feeling. This is probably a more typical picture for what we think of as therapy today. On the top 3 rows, we can treat with rituximab, IV cyclophosphamide, and occasionally you could still use oral cyclophosphamide, although we won't talk very much about that today. In the middle, we have our glucocorticoids with or without avacopan. And then in the bottom, we have adjuvant therapies like plasma exchange. And as we go on to the right-hand side, once people have an induction that is successful and they're in remission, we have options like still azathioprine or MMF, but also now more commonly rituximab going periodically. So any skiers in the, yeah? So this is Whistler from the backside. You can't see it because the skiers are not actually on this side, but this is where you would go if you want to do the off-piste. Okay, so we're going to tackle each one of these separately. We're going to go through what we would classically call the immunosuppressive therapies, although I do realize glucocorticoid and avacopans may also be immunosuppressive. They are immunosuppressive, that's what we've been able to demonstrate, but we'll call this the immunosuppression. And I'm going to put forward that, in fact, in terms of efficacy, I'm not going to show any data because it's generally just pretty similar. There's not a whole lot to talk about in terms of efficacy. You can argue that rituximab might be more effective in people who have previous treatment failure or relapses after induction with cyclophosphamide. That's fine, that's fair. But in terms of your first choice for a patient who has been newly diagnosed, there isn't a ton in terms of efficacy to really sway you. The real swaying comes from what are the side effects and the contraindications to the medications. I've underlined a few of the big ones here. So rituximab, we generally don't give to patients who have active hepatitis B. There is some uncertainty about the rapidity of onset, and we'll talk more about this later. And if you're planning on exchanging a patient, then they may reduce its drug exposure, which may reduce its drug efficacy. On the cyclophosphamide side, well, the first big negative against it is it's called cyclophosphamide and carries with it a scary history of causing cancer. Logistically, there's lots of infusions that are required. We typically advocate the patients go all the way to 10 infusions. That's over 6 months. I think good use of cyclophosphamide also requires fairly intense monitoring, which can be a bit annoying, particularly to our patients. And it can, of course, cause infertility, and it has GI side effects. You can also then think about what about both? They both got some bad things. They both got some good things about them. If we think about regimens recently that have suggested using both rituximab and up to 6 doses of cyclophosphamide, plus or minus IV methylprednisolone and prednisone alone for 2 to 3 weeks, this has now been purported to try and overcome perhaps some of the slowness of rituximab, but also allow us to taper glucocorticoids quite quickly. And you aren't expected to be able to read this, but it suggests that, in fact, disease activity on this regimen in an uncontrolled experiment comes down quite quickly, similar to what we might expect on a traditional regimen, and that kidney function is stabilized in patients who generally had some significant renal dysfunction at baseline, which all sounds quite good, but it is all in an uncontrolled experiment. The black and the gray don't represent two different styles of treatment other than they're two different dosing regimens for their cyclophosphamide and steroids. And this really ends up being low quality evidence. We typically don't recommend this in non-expert centers. It did make its way into KDIGO with some caveats, but it should not be considered the same level of evidence as a standard therapeutic protocol. So if we go back to our two patients, we think about case one who's got significant renal impairment, but not on any oxygen. They're at high risk of kidney failure. There's really nothing to push you one way or the other in terms of cyclophosphamide or rituximab. Some groups will definitely push the idea of doing what we would call dual immunosuppression induction, which is a combination of both cyclophosphamide and rituximab. The high risk of death of this patient also does not really sway us one way or another. There's been nothing to suggest that one drug is superior to the other in terms of reducing mortality. And there really isn't much to suggest there's any difference even in the risk of serious infections between these two, although we really wanted to believe that rituximab would have very little in the way of infection risk. And our second patient, who's now got pulmonary hemorrhage but preserved kidney function, again, not much to suggest that there's anything to do with kidney function here anyways, because they have a low risk of kidney failure. They are at high risk of death because of their hypoxic pulmonary hemorrhage, but there's nothing to suggest that one is more efficacious. And again, there's nothing to suggest that there is a difference in terms of what we do for infection risk. So again, I would just put forward that this is mostly an issue around side effects. Side effects generally, you could say, favors rituximab. Certainly, I think anyone who's used cyclophosphamide for a long time has had a number of often substantial side effects and intolerances from cyclophosphamide that make us more cautious in its use. The cost in Canada, we talk about the cost of drugs all the time. It's a major influence about how we prescribe. And in fact, the costs have actually closed gaps substantially, and facility costs are now part of what drives our equation, in that hospitals have become much more expensive to try and infuse drugs in. And most private infusion clinics won't infuse cyclophosphamide. So that drives a little bit of our thinking as well. Logistics, this is actually probably the single largest thing that really differentiates these two for us. Do you have to come in once every 2 to 3 weeks for 10 infusions over 6 months, or now 2 infusions over the course of 2 weeks for rituximab? Rituximab tends to really be the winner here. The big issue is that private infusion clinics for us are not completely ubiquitous, and they sometimes have a wait time that we are not really compatible with RPGNs. And so we do have some concern sometimes that we just can't get the drug fast enough, and it's not as easy to communicate with them to figure out when they will get it. Fertility, clearly rituximab is the winner here in terms of fertility prevention or preservation. However, the average age of our patients is like 61 to 66, and so that's often not actually a serious consideration for the vast majority, but certainly select patients, that is a big consideration for us. So, if you had taken that first picture in a canoe and you had turned 180 degrees, this is the view of all the rest of Canada, as it turns out. This is, in fact, very close to where I grew up. These are the canola fields outside of central Alberta. And amazingly, there is mountainous regions hidden in the curvature of the earth. All right, we'll move on to glucocorticoids and avacopan. So, Nicholas Sparks, everyone's heard of Nicholas Sparks, I'm assuming, right? You can't escape Nicholas Sparks these days. I have teenage girls and my wife, so I've heard more than I want about Nicholas Sparks. I love you more than there are stars in the sky and fish in the sea. I think you can change to there are more prednisone regimens than there are stars in the sky and fish in the sea. And certainly in some of our developmental work across clinical trials, we seem to discover that for every 40 nephrologists and rheumatologists we ask about their standard regimen, we somehow end up with 45 standard regimens. Sometimes more, depending on how nuanced people like to get. And in fact, we did do some research into this a very long time ago where we took clinical trials tapering regimens and we divided them really just in their stop point, whether or not they went to zero early, they went to zero late, or they never went to zero at all. And based on that, there were some differences in terms of the relapse risk. But that's not important for this talk. What is important is that even among standardized protocols, they differed substantially in terms of what their glucocorticoid exposure was. There was two randomized trials published close together that suggested that there are, in fact, only a few really well-studied regimens of glucocorticoid tapering in ANCA-Associated vasculitis. We were responsible for one, and colleagues in Japan were responsible for the other. So ours is called PEXIVAS on the left, and theirs was LOVAS on the right. There is, of course, a third regimen to consider, which is avacopan-based regimens, largely based out of the Advocate trial, but not ignoring all of the evidence, well, both trials' evidence that came before them. Advocate really looked at what was supposed to be avacopan versus prednisone, but in fact, it turned out to be more like avacopan with some steroids before avacopan, and then some steroids maybe during avacopan for an indeterminate amount of time that also were given against a prednisone taper that ended in zero at 24 weeks. So if we put these side by side, this is each trial by arm and the proposed glucocorticoid exposure with the estimated actual glucocorticoid exposure at the bottom. So you can see in the Advocate trial, the avacopan arm was meant to get close to zero. It's not quite true. It was some uncertainty in the first 4 weeks about what the glucocorticoid exposure would be like. In fact, they got about 1.3 grams of oral prednisone throughout the first 24 weeks. In their prednisone arm, that was meant to be about 2.4 grams up until the 24-week mark, and it turned out to be more like 3.6 grams. LOVAS, which is a trial of patients who had predominantly MPA, so non-relapsing disease, that often involves the kidneys, and this group had non-severe kidney involvement. They got 1.3 grams in the low-dose group and 4.1 grams in the high-dose group. And in PEXIVAS, which is a more severely ill patient population that had renal involvement or lung hemorrhage, they got 2.2 grams in the reduced dose group versus 3.8 grams in the standard dose group, and they were continued on 5 milligrams up to at least 1 year by protocol. Okay, so we have quite a spread, but also quite an overlap in each of these groups, which makes it a little bit difficult to determine the independence of some of these arms when we're trying to think about what do they do. But I'll do my best. I'd first put forward that if we think about LOVAS and PEXIVAS, that LOVAS represents about a 70% reduction in oral glucocorticoids, and PEXIVAS is about a 40% decrease in oral glucocorticoid exposure. they come up with actually quite similar results. Remission, largely unchanged. And in fact, remission in ANCA-associated vasculitis trials is largely unchanged, no matter what we've done so far. It really hasn't, we've never really budged it. Similar mortality in kidney failure, which was extremely low in low-VAS, and similar mortality in kidney failure in PEXIVAS, which was actually pretty substantial. And the serious infections were reduced by about 60% in low-VAS and by about 30% in PEXIVAS, which it only creates 2 points on our dose response curve for serious infections, but it starts to look a little compelling that the more you drop glucocorticoids in the absence of any other differences in protocol, that in fact you'll end up with a greater decline in serious infections. Now, I give you Advocate on its own, and this is the top line results that 26-week remission, very similar. And at 24 weeks, remember, they withdrew prednisone in one group only, and the other group got avacopan for the entire 52 weeks. And by 52 weeks, it looked like there was an increased risk of relapse in those who received the prednisone in the beginning. Glucocorticoid toxicity, I will challenge anyone to truly interpret what the GTI means, but it has a big score that was worse in those who got more prednisone. It's considered to have a minimally important difference of 11. No one really knows what that means. It's based on a distributional system. And so, but it is something. There does seem to be fewer glucocorticoid-related effects in those who receive more glucocorticoids, which is perhaps unsurprising. What might be a little bit surprising is infections. So despite the fact that here now glucocorticoids are cut by about 60 to 70% in the avacopan arm, there is in fact no substantial difference in the number of serious infections or any infections in the avacopan group. Serious adverse events, I like to use this as a way to try and gauge what the GTI means. And in fact, for every 13 patients treated, you avoid one serious glucocorticoid-related event. But if you look at the denominators, even at 3.6 grams of exposure to prednisone, it's about 14%. And that includes some things that are arguably not as serious as others. But of course, one of the real attractions for avacopan was published in 2023 by Frank Cortazar, which was perhaps there may be extra benefit in terms of the kidneys. This is attractive not only because the trial demonstrates what looks like a significant difference. That significant difference looks like it may be larger in those who start with slightly worse kidney function, but it's also nice in that the animal models that looked at the use of C5a receptor inhibition were developed really with the kidneys in mind. And so maybe it makes the most sense that the kidneys get a disproportionate amount of benefit from this. But I would caution you, this is one subgroup of one trial. And so this is not what we would consider typically firm evidence to stand on. So bottom line around prednisone and avacopan, PEXIVAS reduced is probably appropriate for most patients who have renal involvement. We suggest that people use PEXIVAS reduced, and then they alter course if something happens. There's been some publications recently coming out of the observational work from France that suggests that perhaps reduced dose glucocorticoids leaves people open to serious disease activity. That wasn't our experience in a larger, less biased experiment. And it certainly isn't my experience clinically. And one of the beauties of glucocorticoids is that if you start off tapering fairly quickly and you have fairly close observation of your patients, you can adjust very quickly as well. You can put up the dose, you can put the dose back down. Its titratability actually makes it a very nice drug, despite the number of side effects that are attributed to it. For avacopan with prednisone, it is also appropriate for most patients. Again, in Canada, we mostly talk about accessibility of drugs, but in fact, avacopan is freely available to Canadians, and it's very quick. We typically have access in 24 to 72 hours. And so starting patients on avacopan is not a big deal to us. But I always caution people to think about what your goal for avacopan is. If you're trying to use it to reduce glucocorticoids, you should start it immediately, because after about 3 weeks, if you're on a PEXIVAS reduced taper, you've actually lost most of the differentiation in the ability to reduce glucocorticoids. Their exposure has largely been set. They've already got 1.5 grams in, and then you may not want to taper off immediately after starting avacopan. And so you don't really reduce the glucocorticoids that much if you're starting late. However, for many of our patients now, we use avacopan more as an adjuvant agent, and rather than trying to stop glucocorticoids quickly and reduce glucocorticoid side effects, we're aiming for extra efficacy. And that ties into that signal that you see in the kidneys. We think that actually is an indicator that we're not doing everything that we can. The more effective treatment we have that has a lower toxicity profile, the better the chances that we're going to preserve organ function over a longer period of time. And so we're often now using it with a PEXIVAS reduced without adjusting the taper until we're very confident that they're in a good quality remission before we really start to drop the glucocorticoids. So if we come back to our two patients, our one with renal involvement, high risk of kidney failure, some promising but maybe not quite mature data for avacopan. There's two trials that should be launching or just launched that will help solve that. Three trials, I think, actually, that will help solve that question. A high risk of death, really none of these therapies have shown any difference in the risk of death, and that will be a near impossible task for any of these studies. The high risk of serious infections definitely shows that you should avoid something that's close to a PEXIVAS standard regimen, PEXIVAS reduced, or for a low risk patient, you might have considered low VAS, but this would not be considered a low risk patient. For our other patient who has pulmonary hemorrhage, they have a low risk of kidney failure, and so you could argue that it doesn't really matter. Their high risk of death, again, it doesn't really matter. And the risk of serious infections pushes you towards PEXIVAS reduced. Whether or not avacopan on top of that will increase their risk of infection is currently unknown. And then there's this whole idea about the risk of glucocorticoid toxicity, which would definitely favor avacopan. I would just put forward that identifying individuals who you think are at high risk of glucocorticoid toxicity is actually not that easy. Most of those kind of stochastic harms we have, it's difficult to identify a patient phenotype that's at high risk for those. If you look at, they have diabetes or they have a bit of osteoporosis, if you're a nephrologist, you were treating people with FSGS with a milligram per kilo of prednisone for 6 months. No one said anything about them being elderly, frail, or diabetic. We just went ahead and did it. It wasn't a contraindication. We just treated the complications as they came up. So I wouldn't say that any of those are such compelling ideas, particularly in the era of much more rapid tapers and lower cumulative exposures of prednisone, that you have to go with avacopan or you have to taper steroids within 4 weeks of starting therapy. So this is closer to where I live now. This is in Northern Ontario. The trees are in fact turning this color right now. It is a beautiful area. We go then to adjuvant therapy. So in adjuvant therapy, I'm just restricting myself to plasma exchange because that's what I know the best. So the rationale. Rationale is easy. It stems from what all good nephrology does. Remove the evil humors. We think ANCA are pathogenic. We should get rid of those. We can probably attribute a whole bunch of other stuff floating around that we remove with plasma exchanges being bad too. Clotting factors. In fact, in the history of ANCA-Associated vasculitis, giving people therapeutic heparin for a month was common practice in the 1970s. Get rid of all of those things. It will create less scarring, better organ function. It'll make up for the deficiencies and the timing of other treatments. Sounds like a good idea. Bad things. Well, unfortunately, you take out all of the good antibodies as well because we are indiscriminate. And most deaths are now infectious when we talk about ANCA-associated vasculitis. So that might not be a good thing, particularly when we've just finished poking giant holes through their skin directly into their bloodstream. The lung hemorrhage and the removal of clotting factors seems slightly counterintuitive, and the potential effect on medication levels is largely an unknown and poorly studied area. And of course, again, I am Canadian, so I can't help but bring up cost and also the availability of resources that sometimes this requires us to transfer patients for long distances away from their social supports and all the other things that help maintain their health. And that may not always be in their best interests either. So mixed in with PEXIVAS was the plasma exchange question. And I'm just going to start off by saying you don't do everything right the first time, or as it turns out, the second or seventh time either. PEXIVAS was still too small. A lot of people like to go, PEXIVAS, biggest trial, you should definitely just do whatever it says. It was still too small. It has to be taken in the context of all other evidence generated in the area. And we made an assumption that I'll get to around the composite outcome, but we were doing the best we could, but you're always operating with incomplete knowledge when you start, and the retrospectoscope is very effective, but a little too late. So this is the general schema. We wanted to enroll patients who had severe ANCA-associated vasculitis, which we said was kidney involvement with a low GFR or the presence of pulmonary hemorrhage. At that time, we had no good prognostication around pulmonary hemorrhage. We assumed it was all bad, especially if it wasn't treated. They had to be planned to be treated with cyclophosphamide or rituximab. And bear in mind that when we started this trial, rituximab was actually brand new. It was kind of unusual for people to be induced with rituximab at that time. And they had to be willing to use IV methylprednisolone. That was not because any one person felt like IV methylprednisolone was a make or break for this. It was because MePEX had been criticized for comparing the two, and because there was such broad global practice pattern variation that we had to homogenize it, or at least narrow the range of glucocorticoid exposure somewhat. And so we required them to give a range that we thought most people could fall within of IV methylpred as well. They were then randomized to receive either adjuvant plasma exchange or no plasma exchange, and then randomized a second time, or in 2x2, to reduced dose oral glucocorticoids or a standard dose of oral glucocorticoids. And then we followed patients for up to 7 years for the outcomes of end-stage renal disease and death. The participants, I'm very proud of this slide. This may be the most proud I am of anything that we did in PEXIVAS, is it actually looks like the patients I treat. They have an average age of about 63. They are just under half female, and there is a slight predominance of MPO-positive vasculitis, with about 200 patients who had lung hemorrhage, of which about 61 were considered severe by the fact that they had an SpO2 of less than 85% at presentation. And their creatinines were averaging around 300, with the proportion on dialysis at around 20%, which means that, in fact, PEXIVAS was larger than MePEX for the number of patients who were on dialysis or had creatinines of greater than 500 at entry. The immunosuppression is one of those things where, I'm sorry, it's not contemporary, because there was a minority of patients who were receiving Ritux at the time. And in fact, there was no such thing as Ritux maintenance at that time. They developed that partway through the trial, kind of threw us for a loop. In fact, when we were adding Ritux in, we didn't know what to say about maintenance therapy for those who received Ritux, so we just didn't say anything. There's this weird blank in the protocol that just doesn't talk about it. Okay, we'll skip right to the outcome, the primary outcome. This composite outcome of end-stage kidney disease or death from any cause happened in 109 patients in the control arm and 100 in the plasma exchange arm, 31 versus 28%, which gave us a survival curve that looked like this. And you can see that there's that early promising separation in the two curves, in which those with plasma exchange look like they're doing better. But by the third year, they've essentially caught up entirely, and the p-value for that was 0.42. The per protocol population, the 12-month outcome, all of the subgroups we looked at, nothing really changed that result substantially. There's some hints of promise that a lot of people like to talk about, but there is nothing substantial to be able to really put your hat on. We looked at the individual outcomes. Again, not a whole lot there. End-stage kidney disease over the entire course may be a little bit better than death from any cause, but nothing, again, to be able to hang your hat on. So some people said, biggest, highest quality trial in the area, plasma exchange is dead. Do not use it in ANCA-associated vasculitis. It's neutral in all of its primary and secondary outcomes. That's a reasonably fair statement. Other people said PEXIVAS was crap. They didn't have biopsies, adherence wasn't perfect. What about maybe earlier, smaller benefits? Wasn't big enough to find those. And you didn't really study diffuse alveolar hemorrhage, so we don't really think that you can include any comments on it whatsoever. Some of that is fair. Some of that is probably not fair. And I would suggest that the biggest mistake we made was our composite outcome. When you design a trial and you go, ooh, this is going to be hard, you look for outcomes. You want outcomes. And we often naively believe that the more outcomes, regardless of what they are, the better. But in fact, what you need is you need outcomes that move in the same direction by similar magnitudes through the same causal mechanism. We thought that was going to be death in addition to end-stage kidney disease, but it wasn't. We made a very cogent argument. We convinced lots of smart people that that was a good decision. We convinced ourselves it was a good decision. But in fact, death doesn't move quite like end-stage kidney disease does. So we did a meta-analysis. We actually did it right after the trial, but then COVID happened right with the trial. And so there was some problems getting this one out. And we demonstrated that all-cause mortality does not look like it shifts substantially. In fact, we're fairly confident that all-cause mortality doesn't shift by any important measure by using plasma exchange or no plasma exchange. And sorry, I should mention, there is no difference in that effect for the subgroup that has lung hemorrhage versus those that didn't. We actually used reasonably sophisticated methods to be able to get to that answer. On kidney failure, however, it looks like there is a substantial reduction. This is, a 35% reduction in the risk of end-stage kidney disease by 1 year. Now, that effect wanes over time. So by the time you get to 3 years, most of that effect is gone. But I would argue for most people, staying off dialysis for 3 years is pretty important. And in fact, that's the same size effect as you expect out of an SGLT2 inhibitor. So we're all pretty enthusiastic about SGLT2, but for some reason, the plasma exchange thing seems to have generated a fair bit more controversy, maybe because it's taken 20 years to get to the answer. And serious infections was a surprise. In fact, in the meta-analysis, we included serious infections not because we thought that there was anything to it, but because it was just included in the list of important outcomes that patients and practitioners wanted answers to. And so it was thrown in. And to our surprise, there was a 27% fairly consistent increase in the risk of serious infections. We always talked about this, but no other plasma exchange trial in any condition has actually shown a serious increase in the risk of infection. Part of that is because when you take a look at the use of plasma exchange in particularly neurology and hematology, those patients don't get serious infections to begin with. So there is no serious rise to be able to demonstrate because a 27% rise for them means that they go from 1% to 1.27%, which they would require 10,000 patients to be able to detect, which has not been done. So because our baseline risk of infection is so high, we actually have substantially more power to be able to demonstrate an effect on serious infection. So if we go, well, what does this mean to patients then? We go like plasma exchange works, but it causes infections. Well, plasma exchange works, and there is no evidence that it actually differs in its effect on kidneys across their presentation. So that means, though, that some patients have very low risk of ever developing end-stage kidney disease. That leaves it very little room to actually make any improvement in their health. If we give the example here that if you're at a 0.2% risk of end-stage kidney disease without plasma exchange, it's still effective, but it only changes it to a 0.1% risk, which means that you get one fewer for every 1,000 patients you treat. If instead you take a group of patients with ANCA-associated vasculitis that without plasma exchange would have a 5% risk, it drops to 3. And now you have to treat 50 patients to prevent 1 case of end-stage kidney disease. Plasma exchange, not the most benign thing in the world and a little bit to actually get it going. So maybe that's not the right threshold for you to consider starting. When you get to a risk of about 11%, you're now treating 25 patients to prevent 1. If you get all the way up to 38%, and I know that sounds like a very weird number, but it was chosen on purpose, that gets you to about 7 before you prevent 1 case of end-stage kidney disease, which I would prefer to is actually pretty important. Treating 7 patients, you have to treat the blood pressure of a lot more patients, but of course, it's a much more innocuous chronic therapy. However, there's a parallel to this, which is infections, which is going the wrong direction. And interestingly, the risk of infection closely parallels the risk of end-stage kidney disease. The higher your risk of end-stage kidney disease, the higher your risk of having a serious infection. They are not perfectly parallel, so you can't draw exactly the same cuts. But if we theorize that we can identify a group of patients with a 10% risk of serious infections, well, then it takes 33 treated with plasma exchange before you cause one extra. If you get up into the 50%, which are that are severely ill patients with ANCA-associated vasculitis, by the time you treat 6, you've caused one more. So in this high-risk renal group, you'll prevent one case of end-stage kidney disease and you'll cause one more serious infection. You go, well, how am I supposed to identify these people? Well, you can use something like the ACRIS score, which Silke Brix has proposed, which uses biopsy and clinical parameters to be able to differentiate patients into various groups. You can see that there's several. It goes out all the way to 12 years of follow-up. But in fact, all the action is in the first year. So when you predict the short-term outcome using ACRIS, you actually get a better, more accurate result than when you try and do long-term prediction. And I would suggest when you're talking about acute therapies, you're typically just casting your horizon to about a year anyways. If you're going too far beyond that, there's all sorts of other stuff that's going to happen in the average 66-year-old that make prediction not so useful. We have a paper that's been in preparation sitting on the back of my desk for a very long time that suggests that if you're like our group and you actually don't do that many biopsies in ANCA-associated vasculitis, because we often don't feel we need them, we're very confident in the diagnosis, and we feel like you can probably prognosticate accurately without the biopsy, serum creatinine alone actually has excellent operating characteristics. Combined with whether or not they require dialysis, you basically draw a straight line for their serum creatinine represented in black, or you draw a dotted line for those who require dialysis, and you can check where they're going to lie. If they have normal creatinines, 0.2% chance over the first year. If they've got a creatinine of 2.8, I remember to change the units for you, about a 5% chance. Creatinine of 3.4, you're getting into the 7.5% chance. And if they require dialysis for some reason at that time, it jumps to 17.5. And once you get up into the creatinines of 5.6, 15%, and if they require dialysis, 30%. And it does continue to go up. And I'd suggest that's actually enough for most people to be able to make decisions. You don't have to know if it's 52% or 47%. What you need to know is there going to be much benefit or not much benefit? And most patients want to know, am I likely to end up on dialysis? Is this really going to help me? Serious infections, this is now unpublished work that's about to be presented. So we think we can predict serious infections in the first 6 months. One of the problems is that they're so prevalent that it's actually quite hard to differentiate different individuals. So we use a model that includes 17 clinical characteristics at baseline for their induction, and we're able to calibrate it fairly well, but that's because there's so many infections that in fact it's like 30% throughout most of the group. It doesn't truly differentiate that great actually between them, and so this is stuff that needs further work and honing as time goes on. What about with diffuse alveolar hemorrhage? So this always comes up. I typically try and dodge it, but try and deal with it here. So we said there is no benefit found on mortality for any group of patients with ANCA-associated vasculitis and plasma exchange. The goal of exchanging someone with alveolar hemorrhage is to save their life. And so if there's no mortality benefit, it leaves you really not a lot of reason. And in fact, there was no benefit even on a potentially more sensitive measure of ventilation or duration of ventilation. We couldn't demonstrate we got people off the vent any faster with plasma exchange than we did with no plasma exchange. And the risk of infection, we're fairly confident, is increased, and that is by far the most common cause of death in those who have high-risk pulmonary hemorrhage. And so you may, in fact, exacerbate the mechanism by which people die with alveolar hemorrhage. I'm not saying that you might not be able to reduce the intensity of their pulmonary hemorrhage, but you're trading it off for something that may be just as bad. So we have suggested that you only use if there is a concomitant risk of kidney failure that motivates your decision to use plasma exchange, or if the risk of death is already so high that you are tossing the proverbial kitchen sink at them, which does happen. But in fact, when we talk to our critical care colleagues, because we wanted to be able to define that phenotype, they said, no, we can't really do that. In fact, modern ventilation is so good that the kitchen sink comes so late that they're essentially already about to die by the time we make the decision that we're past the point of no return. And so it makes it very hard to decide. We very, very rarely use plasma exchange for pulmonary hemorrhage in our unit now. Okay, so we get back to our patients. Our first patient who has kidney involvement, high risk of kidney failure would suggest PLEX should be offered. High risk of death doesn't really matter. High risk of serious infection is counterbalanced on the no PLEX. are a patient with pulmonary hemorrhage. Low risk of kidney failure would suggest PLEX not needed. High risk of death still, but plasma exchange won't affect that, so it doesn't really help us. High risk of serious infection suggests no PLEX would be favored. What do the guidelines say about this? So KDIGO, right after PEXIVAS was published, said still consider it for life-threatening or organ-threatening disease with a creatinine of over 5.6, which was actually based on MePEX being considered separately from PEXIVAS, and continue to consider it in DAH with hypoxemia. That was the mentality of throw the kitchen sink at it right away because that's a bad disease. That was prior to the meta-analysis coming out and suggesting that infection was a serious problem. ACR generally said, don't use it unless there's something special. EULAR came out a little bit later. They had the benefit of having more data to be able to work with, and they said consider it for life or organ-threatening disease with a creatinine of over 3.4, but do not use standard in DAH. And the apheresis guidelines, which are really always very interesting to read because those guys are so used to dealing with just an incredible paucity of data. They go, if there's RCTs in this area, the whole thing gets elevated in terms of the level of evidence that guides the recommendation. And they go, accepted second-line therapy, strong recommendation, moderate evidence. DAH, accepted first-line therapy. Was based on the guys told us it's good. KDIGO altered its recommendation in 24 with lowering the cutoff to consider use for organ or life-threatening to a creatinine of 3.4 mg per deciliter. And this is reflected in how we wrote it in the BMJ rapid recommendations as well. We realized after this that, in fact, no nephrologist and most rheumatologists don't read the BMJ, and so it was hard to get that message out. But we said that there was a weak recommendation against using it in those with low or moderate risk of developing end-stage kidney disease, a weak recommendation to use it in those who are at higher risk, and a weak recommendation against using it in those with pulmonary hemorrhage without kidney involvement. Weak recommendation in grade guidelines does not mean that it's not good evidence or we don't think you should do it. It means that there is between 50 and 90% of patients we think that would accept this therapy as being used in this condition. And you should individualize treatment and decision-making on the basis of the patient in front of you and the totality of information. A strong recommendation suggests that greater than 90% of patients would want this, and you don't have to engage in serious shared decision-making. You should just go and do it. You should offer that as being first-line accepted therapy. So a nuance that I think is also often lost in the way in which grade works. So this is the other end of Canada now. This is the Gros Morne in Newfoundland, which is one of the most beautiful national parks we have, but often very little known because it's not considered mountainous. Okay, so in summary, choosing between cyclo and Ritux, not really based on efficacy, really based on side effects and logistics. Prednisone tapering regimens recommend that PEXIVAS reduced plus or minus avacopan is generally appropriate for most patients. But I just urge everyone, consider the goal of adding avacopan into your therapies. Are you trying to achieve higher efficacy or are you trying to reduce glucocorticoid exposure? Because they're really quite separate things. Plasma exchange does reduce the risk of 1-year end-stage kidney disease, but it increases the risk of infections. We can say that with what's considered moderate to high certainty, and large trials in rare diseases are possible, and we really do still need more of them. We still don't have the kinds of outcomes we wish, and it is, of course, very heartening in nephrology to see that happening in many of our glomerular diseases now. Lots of people to acknowledge. The list actually goes on and on and on and on, but we ran out of space. And thank you all for listening.